Thank you so much for having me. This is very exciting. You're having me talk about one of my favorite topics, so I'm very happy to be here. So my name is Miriam Sklerov. I'm a movement disorders neurologist at UNC, and I do the autonomic testing for our department. It's a long story how that I got into that, but autonomic dysfunction affects a lot of my patients, a lot of our patients. So yeah, I'm very happy to be able to bring that to UNC. So I'm going to talk about autonomic symptoms in dementia and Lewy body dementia today. And I really don't have any disclosures that are relevant to this talk. So first, as a little background, what is the autonomic nervous system? Well, the autonomic nervous system is the part of the nervous system that takes care of, in a nutshell, the things you don't really have to think about, right? Sweating, breathing, blood pressure, heart rate, going to the bathroom, sexual function, sweating, and as you can see here, I mean, you have your autonomic nervous system is innervating almost every part of your body and doing some sort of function, even your eyes, right? It controls pupillary dilation and constriction in response to light and many other things. So, and what you're going to see is that as a result of this, when the autonomic nervous system is not functioning well or has some, is undergoing some neurodegenerative changes, we can have a whole host of symptoms that is really just related to this problem. Now, some of the most common symptoms or most common areas that people will have symptoms in LBD with regards to autonomic nervous system dysfunction are orthostatic hypotension, which is what happens to some people when they stand up, their blood pressure drops. Normally, when we stand up, gravity pulls all of our blood down towards our feet, down, and our autonomic nervous system kicks in pretty quickly within seconds and starts to make changes to try to pump that blood right back up to the brain, because obviously the brain needs blood all the time, every second. And without enough blood flowing to the brain, people can pass out and have other symptoms. So orthostatic hypotension is a fairly common symptom in dementia with Lewy bodies. It affects probably at least half of people who have LBD. We also see constipation. Constipation is probably the most common autonomic symptom in LBD. And we take it very, very seriously. Constipation can be medically very, very serious. We have seen bowel ruptures. We have seen some really, really nasty effects of untreated constipation. So I will talk more about constipation, but I do urge you, if you've been experiencing symptoms of constipation, make sure that you are talking to your doctors about that. Urinary symptoms, also very, very common. The most common symptoms would be urinary urgency, meaning the moment from the time that you feel that you need to go to the bathroom to the time that you have to be going to the bathroom is a very short period of time. Then we also see people experiencing urinary frequency, meaning that it's defined as having to empty the bladder again within 2 hours of the last time that you emptied the bladder. And that can happen during the day and at night, which is obviously problematic. And then urinary incontinence also is a common symptom. We also can see what's called urinary retention, meaning trouble actually emptying the bladder. So I'm going to talk a little bit about more about that later as well. We can see sexual symptoms. In men, we can see, when it's a purely autonomic, we expect to see erectile dysfunction and anorgasmia. In women, we can see anything from lack of arousal to vaginal dryness and also anorgasmia as a symptom. We'll talk about that as well. We can have dry mouth, or the opposite. We can have drooling or too much saliva. Also, some people can experience dry eyes as a result of autonomic dysfunction. And I'll talk a little bit more about some of those as well. Then sweating. So I do hear a lot about excessive sweating. Excessive sweating is usually more bothersome for people than the opposite problem, which also occurs, which is reduced sweating or even absence of sweating. And in fact, what's interesting is when the sweat glands are involved in the autonomic nervous system innervating the sweat glands is involved. Early on, the major symptom people can experience is too much sweating, and then later on, as the sweat glands are more and more affected, we get the opposite, where there's reduced sweating or no sweating. We also can see cold extremities or discoloration of the fingers and toes. Some people notice redness or purple or blue discoloration, and, especially in the fingers and the toes. And that is also a symptom of autonomic nervous system dysfunction. People can also experience visual changes. As you know, there are a number of reasons that people can have difficulty with vision when you have LBD. But autonomic nervous system dysfunction is one of those, can be a contributing factor, especially as I mentioned, for example, one of the autonomic functions in the eye is to dilate and constrict the pupil. It also does what's called accommodation, which is adjusting the lens inside the eye, depending on what you're looking at. So there also just tearing, lacrimation, and making sure the eyes don't get too dry. Those are all autonomic functions that can be affected in LBD. Okay, so I have picked out some of the symptoms that I personally hear about a lot, and I know a lot of my colleagues hear about from patients that are particularly bothersome, but also symptoms that, when we look at research, we see that these are some symptoms that really impact people, from not just not just a personal level, I would say, but even a quality of life and even survival with LBD. So I really wanted to get a little bit more into these symptoms, but at the end, if people have other autonomic questions that I didn't really talk about in this in my slides, I'm happy to address them as well. So orthostatic hypotension, as I mentioned, is a symptom where means that when you stand up, your blood pressure can drop. And sometimes it's 20 points, 30 points, but commonly people can have very severe orthostatic hypotension where the difference between their sitting blood pressure and their standing blood pressure could be over 100 points. And obviously, this is a big problem. You're not getting blood flow to the brain. It's limiting your activity levels, because if every time you stand up your blood pressure drops, obviously you're going to be very limited in what you can do. But we've also found that people who have orthostatic hypotension and also have LBD, and this actually goes for Parkinson's disease and multiple system atrophy, other neurodegenerative conditions, it does also seem to impact the prognosis on the entire disease. So that's why we take it very seriously. We do make sure that we address it and treat it as we can. So some symptoms. I do want to mention this because we think of you think of when people have low blood pressure that they probably feel dizzy. And yes, that is a common symptom, feeling lightheaded, feeling dizzy, but there are a whole other set of symptoms that people can experience even without having any dizziness. So one of the symptoms, one other symptom that I hear a lot is just being tired. In fact, I think that one is even more common. I hear that more than feeling lightheaded or dizzy. And pretty characteristically, people will say, maybe I feel a little funny when I stand up, but then the longer I stand or the further I walk, I get just so tired. I have to lie down. We call that, or sit down, and we call that exercise intolerance. But really, it's because with neurogenic orthostatic hypotension, so the orthostatic hypotension that happens as a result of neurologic disease, what we see typically is the blood pressure can drop right when you stand, but even more often what we see is that the longer you stand, the lower the blood pressure goes. Other symptoms that people might experience is change in vision with standing for a prolonged time or walking. So a lot of times darkening of the vision or even tunnel vision. People can also feel hot, a little overheated. People also, one not uncommon symptom is stomach upset. People can feel like they're going to throw up. I'm trying to think of other symptoms. There's this one that we talk about actually among autonomic circles, but it's called the coat hanger syndrome. And what it is coat hanger syndrome. People feel either a pressure or even outright pain in their neck and shoulders. If you think of the shape of a coat hanger. And that can be their only symptom of orthostatic hypotension, which of course can become a little hard to diagnose because you're not expecting that to be caused by blood pressure. But I do see that not infrequently as a symptom all by itself of orthostatic hypotension. So how do we diagnose orthostatic hypotension? How do we tell that you have it? Well, the easiest way is if it's suspected, we can test your blood pressure when you're lying, sitting, and standing. So typically in the office for all of my patients, I always check blood pressure sitting and standing at every visit. And that gives me a clue. Sometimes that's not sensitive enough to pick up orthostatic hypotension. So if that's not really showing us what we're looking for, and we still have a pretty high suspicion, we can order what's called autonomic testing. And a lot of autonomic testing, they do just what's called this tilt table test, which is what this picture is showing, where they have you lie on a bed, and we measure your heart rate and blood pressure while you're lying there for at least 5 minutes, and then we tilt the bed almost upright, almost completely upright, while you're strapped in there, so you fall off. But and then we measure your heart rate and blood pressure for at least 10 minutes while you're upright. And that way we have a longer period of time, and we're better able to capture if there's this delayed drop in the blood pressure, which we often see in the orthostatic hypotension associated with DLB or LBD, excuse me. So in addition, at a full autonomic lab, you may also have some breathing tests that we do, and we measure your heart rate and blood pressure in response to some of these breathing challenges. And that can also give us a lot of information about whether or not there's cardiovascular, appropriate cardiovascular responses, autonomic responses to these challenges. Okay. Now, in terms of treatments, so, the medications that we use for orthostatic hypotension have their own side effects, just like every medication. So the first steps in treating these symptoms should be non-medication, right? The first thing I always do is I look at the medication list that you already have and see, are there medications on there that are lowering your blood pressure or making this problem worse? Obviously, things like antihypertensive medications, right? Medications that you're taking to lower blood pressure. Those would be the first on my list to see if we can get rid of. It may not be safe to get rid of them. That's why I always talk to the doctor who prescribed them. But as much as possible, we try to get rid of these. There are also other medications that lower blood pressure, like diuretic medications, ones that make you get rid of fluid. There are also some urine medications that can lower blood pressure. So we really do a very comprehensive screening of your medication list to see if there are things that we can just get rid of. And sometimes that's all it takes to improve symptoms of orthostatic hypotension. The next thing is what I call conservative interventions, meaning non-medical interventions, non-medication. And in my next slides, I'm showing you a handout that I give to all my patients who have orthostatic hypotension, and it goes through some of them are interventions that you can do at home to really improve the symptoms, and then it also goes through triggers. So trying your best to avoid triggers that will make the blood pressure lower or make this problem worse and are more likely to bring out symptoms. And then, of course, we do have medications that are meant to increase blood pressure. Now, I want to say it that way because unfortunately, we don't really have medications that narrow the gap, that make the drop less. We're not there yet. But the medications that we use, what they really do is they kind of raise the low blood pressure, but they also raise the high blood pressure, which I haven't mentioned yet. People who have orthostatic hypotension, so their blood pressure drops when they stand, they oftentimes also have the opposite problem where the blood pressure can be too high when you're lying down. So what we run into sometimes is problems with these medications is that, yes, they're helping to increase the low blood pressure when you're standing, but they're also increasing the high blood pressure when you're lying down. So I'm going to go through some of these tips that I give out to patients on what you can do at home, non-medical, to really improve these symptoms. So as you can see, the very first thing on here, and the thing that I harp on the most, is about hydration and salt. So the amount of water that everyone should be drinking is really based on your weight. So we can calculate it, but for people who have orthostatic hypotension in the context of LBD, I know that their water requirements are actually probably higher than what we were going to calculate. So a good ballpark, a good number to keep in mind is about 2 liters, which is about 64 ounces of water per day. And I do mean water. I don't mean tea, coffee, soda. I mean water. Because all these other drinks can have caffeine, which is a diuretic and make the problem worse, make you get rid of your water. They also kind of dilute the water. So water, we're talking pure water. You can put a little lemon in it. You can put a little, flavor a little bit, but it should be water. Now the salt, we do sometimes recommend salt tabs. I do not personally do that because salt tabs are very expensive and it's not much different than just salting your food in the end. So, and also there's actually not good evidence for the use of salt tabs for orthostatic hypotension. So I do encourage people to talk about the salt with their doctor, though, because of course there are certain medical conditions where it's probably not safe to be increasing the amount of salt you eat. So that should be discussed with your doctor. The second item on here is compression stockings and abdominal binders. So when you stand up, what's happening, gravity's pulling your blood down, but that blood, where it's going is to where there are biggest veins in your body. And the 2 areas that have the biggest capacitance, venous capacitance, meaning the most number and biggest veins, is your thighs and your abdomen. And I say it like that because what I find is people come to me with orthostatic hypotension. A lot of times they have been told about the compression stockings, but they're only wearing knee-high stockings. And that has been shown not to be helpful for orthostatic hypotension. And that's probably because the big veins are in your thighs. So if you're not compressing the thighs, you're probably not going to notice a whole lot of benefit. So I do recommend the compression hose, if you can get them on, the ones that go all the way up, to your belly. Those are really hard to get on. I do appreciate that. And I know that mobility is also an issue. So typically I ask my patients to wear thigh-high stockings, compression stockings. And then in addition to that, add an abdominal binder of some sort. It can be one of those post-surgical binders that you can get at Walgreens. It's a big elastic band with Velcro that you wrap around yourself, or even women's Spanx, the what are they called? The undergarments that hold you in, anything that really squeezes your belly. I even tell people sometimes, bike shorts, exercise shorts that really squeeze your thighs and your belly can also be very helpful, and a little bit easier to get on and off. And then the rest of these on my list, actually it's 3 slides with these recommendations. It's mostly recommendations about avoiding triggers, or at least being aware of triggers. For example, large meals. A large meal, after you eat a large meal, all your blood is rushing to your belly to help digest. And if you're detracting that blood already from your head to go to your belly, and then you stand up and that blood's going even further down, your problem's going to be worse. So it doesn't mean don't eat large meals. It means that just be aware after a large meal, you just have to be a little bit more careful. And that goes for carbohydrates as well. This problem is actually a little bit more exaggerated when you have a big carbohydrate load. Alcohol also reduces blood pressure. So after you have even a small glass of wine, your blood pressure will be lower for a brief period of time. So just be more careful. If you are going to drink alcohol, make sure you're not going to walk a mile back to your car afterwards, because that could be problematic. And then again, I mentioned that when people who have low blood pressure, when they stand, often can have very high blood pressure when they're lying down. So when I know someone has orthostatic hypotension, I always recommend that you sleep with your head elevated. Anytime you're lying down, it should not be flat. Depending on the severity of the high blood pressures, if they're in the 160 to 180 range when you're lying down, I'll usually say, okay, 30 degrees is enough. If you have, a hospital type bed, or a bed that you can elevate the bottom, whatever, the top half of the bed, that's a great way to do it. Otherwise, wedge pillows tend to work really well. Stacking regular pillows often doesn't work well. They move a lot. People end up completely flat by halfway through the night. So I would recommend a wedge pillow as opposed to just regular pillows. If the blood pressure is really high when you're lying down, in the 200 range or above, then people should never be lower than 45 degrees when they're lying down. Exercise lowers blood pressure. While you're exercising, usually blood pressure is pretty good or even a little bit higher. But immediately after exercise, there is a period of time where your blood pressure is actually lower than normal. That's true for everybody. But if you have orthostatic hypotension, it's just a time that you just have to be a little bit more careful. Obviously, exercise is very important in LBD. It really, everybody needs to exercise. This is just a reminder that when you're getting off of the exercise bike or coming out of the swimming pool or whatever exercise you're doing, make sure that you're doing it very slowly, very carefully, and there's someone there to monitor in case your blood pressure does drop. And this is a reminder that everyone's blood pressure is lowest in the morning, especially early morning hours between around 5 a.m. to 8 a.m. for most people. That's oftentimes when orthostatic hypotension symptoms are the worst for a lot of people. So I often will tell people, make sure you drink a full glass of water before even trying to get out of bed. If you're taking medication for orthostatic hypotension, take it before you get out of bed, because early mornings when we do tend to have more difficulty. And then extreme heat. Anyone who's been outside in a really hot day or been in a sauna too long, you get a little lightheaded, you feel a little bit woozy, because heat does lower blood pressure. And if you have orthostatic hypotension, this can be potentially very dangerous. So I do recommend avoiding being outside on a really hot day. Saunas, hot yoga, steam rooms, even hot tubs, even being in the shower, taking a hot bath. You may need to consider avoiding hot baths. You can take a hot shower, but make sure that you're seated in the shower and very careful when you're getting out of the shower. And then, of course, if you're feeling that symptom, whatever your symptom is of orthostatic hypotension, if you start to feel it, don't wait until it gets worse. And the moment you feel it, make sure you sit down or lie down, because sometimes it can go from 0 to 100 very quickly. And that's when I see a lot of people pass out, when they kind of ignore the early symptoms of not feeling great. Okay, so medications. I'm trying to clock myself because I want to make sure we have time for questions. So these are the 4 primary medications that we use to treat orthostatic hypotension. The choice of medication has to do a lot with each individual patient. So each person, if they have other medical problems happening or other symptoms, we may choose one over the other because they all have slightly different side effect profiles. So I won't go into this too much unless people have specific questions at the end. But I will say that none of these have been specifically tested in DLB and LBD. There is a smattering of small studies in Parkinson's disease, but most of these have only really been trialed in exception of droxidopa, but most of them have been only really tested in all comers with orthostatic hypotension, so not even just neurogenic. But despite this, this is our armamentarium. So these are the ones that we use. And in my experience and the experience of my colleagues, they are very beneficial. But again, as a reminder, they increase the blood pressure. They don't narrow the gap. So we do have to be very mindful of also measuring lying down blood pressures as much as we're measuring the standing up blood pressures and paying attention to them. Okay, so I'm going to move on to constipation and stool incontinence. I'm going to do them together because oftentimes people who have constipation can also develop stool incontinence. Typically, we'll see constipation first and we'll see it earlier. Stool incontinence oftentimes can happen in later stages of LBD, but it can also happen after a long time of constipation. So symptoms are, of course, the definition of constipation is having 2 or fewer bowel movements per week. That's the most widely accepted definition. We don't, in practice, I don't use that definition because there is the normal range for a normal number of bowel movements is quite wide. In people who don't have constipation, you can have bowel movements as few as 3 times a week and have that, and that may be normal for you, or as many as 3 times a day, 2 to 3 times a day. And that could all be in the normal range. So if you're someone who used to have a bowel movement 1 or 2 times every day, and now you're having a bowel movement, 3 times a week, I'm still going to call that constipation most likely. Other symptoms that people can experience, of course, is abdominal bloating, change in the stool consistency, straining with the stool, bleeding when having a bowel movement, and actually some abdominal pain is also is also a common symptom of constipation. How do we diagnose it? Well, first we take a history, right? We say, okay, I'm not having bowel movements as frequently as I used to have. So we care about frequency, but we also care about consistency. This is the Bristol stool chart. Yes, it's a picture of poop, but I use this very commonly, and most people who treat also will use the Bristol stool chart. And it does give us an idea of how severe constipation is, whether you're constipated, and what kinds of things can we do to help. Also, if someone's having the opposite problem, stool incontinence, this can also help us understand how to target it, how to improve the symptoms. And as you can see here, type 1 is severe constipation. That's like rabbit pellets. That's usually a cause of concern. If I have someone who tells me that's what their stool looks like at least part of the time, I will be more aggressive at treating this. Type 3 and 4 are considered normal. I wouldn't be too concerned about type 3 or 4. Anything type 5 and below is definitely considered too soft and can sometimes lead to stool incontinence. Okay, so how do we treat? I in terms of diagnosis, I don't typically need additional testing. Sometimes if I have a concern about something else going on in the abdomen or not responding to treatment, we could consider some x-rays of the abdomen to see what's going on, or even something more invasive like a CAT scan. But typically I don't need additional testing to make a diagnosis of constipation. So treatment, first, always look at the medication list. There are a number of medications that cause constipation. And surprisingly, I see a lot of people taking them. So the number 1 and number 2, I don't know which one's 1, which one's 2, medications that I see that I often will try to remove, excuse me, are opiates, so pain medications, and anticholinergic medications. So medications often that are used to treat urinary symptoms. We can worsen or even cause constipation. They can also cause other not so nice symptoms in LBD, such as confusion. So in general, we try to stay away from those medications. And then there's what we call the conservative or non-medication interventions. So I always talk with my patients about diet. So primarily high fiber diet, water. So I had someone who trained me when I was a resident used to say, if you're having a lot of fiber and not enough water, all you're doing is mixing concrete. So I'm just going to leave that there. But the water intake I usually recommend is about the same as what I do for the orthostatic hypertension. 2 liters is a good ballpark. Exercise. So people with neurodegenerative diseases often are more sedentary than they used to be. And being sedentary is a risk factor for developing constipation. So just getting up and walking, not even necessarily cardiovascular exercise, but just being off your butt can really improve constipation. And then I cannot emphasize enough how much I have benefited, or my patients have benefited, from pelvic therapy. So pelvic floor therapists are physical therapists who have training and specialization in pelvic floor. And you can find pelvic floor therapists anywhere. But they really concentrate on, some of it is strengthening of the muscles that are involved. They also work on dyssynergia, which is when the muscles of defecation are not coordinating properly. So you're not relaxing, and or your sphincters, for example, are tightening instead of relaxing when they should. They can work on some of those coordination issues. They also talk about proper positioning, and behavioral modifications that need to happen, dietary things that need to happen. So I find it very, very helpful to have pelvic floor therapy involved. And then we have medications. So again, these have not specifically been tested in LBD. Most of the data, and these drugs that I'm listing here, these are the ones that have been tested in Parkinson's disease. And there are others. So, I mean, in general, we do treat constipation very similarly in LBD as we do in anybody else who has constipation. But first, we start with these non-medication interventions. But if that's not enough, or if the constipation is really severe, then we start adding some of these agents here. So psyllium is also called Metamucil. Polyethylene glycol is also known as Miralax. Those are my two, first line go-to, and tend to be very effective. Amitiza or lubiprostone was tested in Parkinson's and seems to be effective. So that is another option. Honestly, by the time, if we get to that point, if the first couple things I've tried aren't working, I usually do send people to see a gastroenterologist. One, to make sure I'm not missing something else going on, but two, also because they have a little bit more experience in treating more resistant constipation. Okay, I'm going to move on. Okay, I'm doing okay on time. All right. So the next symptom that I hear quite a bit about and is very bothersome to my patients is excess saliva, which we call sialorrhea. So excess saliva is, the symptoms are, as you can imagine, people can have drooling, and typically it can happen at night, or it can happen in the day. Oftentimes I hear about it first at night, and then people might start noticing it during the daytime as well. I also, when I'm trying to understand, the saliva itself, I want to know how much is it interfering with your function, right? Is it embarrassing? Is it keeping you from interacting socially with people, like, as we learned, which is very important for people with LBD to do. So we don't want anything inhibiting that. Is it making it hard to eat or speak? We also, I also will ask about swallowing. So one of the mechanisms that contributes to excess saliva in LBD is difficulty swallowing. So we want to make sure that there's not choking hazard or other problems that we need to address with regards to swallowing. I also want to know, how bad is it? Is it just, once in a while you have to get a tissue and wipe, or are you carrying around a roll of paper towels or a towel with you all the time because it's just a constant flow? Okay, and then how do we diagnose it? It is a clinical diagnosis, meaning just you telling me about the symptoms or me seeing it is enough for me to make the diagnosis. I don't really ask for additional testing unless I'm worried about a swallowing problem. I do, in my patients, I often do get regular swallow studies anyways. So that can be helpful, and a speech therapy evaluation can also be very helpful. And then treatment. So there are a few medications that can cause or worsen drooling. Unfortunately, the acetylcholinesterase inhibitors, which are the things like donepezil and rivastigmine, which we use for cognitive symptoms, can cause drooling. So sometimes we do have to do a little bit of a risk benefit evaluation. I don't think I've ever taken anyone off of one of those medications for drooling. Instead, we opt to treat the drooling in another way, or the saliva. But it's something to consider. The pyridostigmine that I mentioned as a treatment for the orthostatic hypotension can also do this. And that is something that I probably would consider taking someone off of if they're having excessive drooling as a result of that medication. Non-medical interventions. So sometimes something simple like sucking candy or chewing gum, it stimulates the swallow reflex and helps get the saliva down before it comes out. and that can be all people need. One of my speech therapists also recommends carrying a little wristband, those little terry towel-like wristbands that people who are active in sports sometimes wear, and it can be very subtle if you want to dab instead of having to get tissues all the time. So those are some things that we can do that are non-medical. And then we do have medications. There are oral medications. And again, these are things that have been tried not in LBD. They've been tried in other conditions where people have trouble with excess saliva and in Parkinson's disease. But we find that anecdotally in my patients, they can be very effective. So there's oral medications, which is glycopyrrolate, atropine eye drops, but not in the eye. You put them actually under the tongue, and amitriptyline. Unfortunately, oral medications always have the potential of being absorbed. They're all absorbed, and that means they can go anywhere in the body and cause side effects anywhere. So in general, I do prefer botulinum toxin injections as a treatment for excess saliva, because botulinum toxin is Botox. You've probably heard of Botox cosmetically. You may not have heard of Botox for other reasons, but Botox actually is a medicine that we made for use for things like dystonia or abnormal muscle contractions, and we find that it's very beneficial for reducing for saliva production. And it was incidentally by accident that we found out that it also helps wrinkles, but that's another, So the botulinum toxin injections, we actually inject directly into salivary glands. And the nice thing about the Botox is that it isn't absorbed into your whole system. So you're not getting side effects. You're not getting foggy brain or nausea or some of these other side effects that you get with oral medications. And the side effects are just limited to where you're injecting. And the good, I guess, part is that it wears off. If you don't like the effects, it goes away after a couple months. The annoying part of the Botox is that it's very expensive, and hopefully it's covered by insurance, but not always. And two, that you have to get it every 3 months, right? So it's not a one-time fix. But that is usually my preferred method of medication, or my preferred medication for treating excess saliva. Okay, so urinary symptoms. I'm going to speed up just a little bit so we have time for questions. But so urinary symptoms. So the most common symptoms, as I mentioned, are frequency and urgency and incontinence, so losing control of the urine. And that can be just a little dribbling, or it can be an entire bladder loss of urine. We can also get urinary retention or difficulty emptying the bladder. Now, what we found in studies is that the symptoms that people experience often don't correlate with what's actually happening in the bladder, meaning that people who have very frequent urination, you think that may be a sign of the bladder just being too sensitive or too active, hyperactive, but it can also be a sign that the bladder is too full. So people have been not emptying the bladder for a long time, and as a result, now every time that something's coming out, it's an overflow. So for that reason, if people are having urinary symptoms, these are types of urinary incontinence, as you can see. So there's problems with the bladder being too sensitive and just spasming too easily. And then there's the other problem where the bladder's too full and trying to, and anything that's coming out is just having to push really hard against a really closed tube. So I usually do recommend that people see urologists because they have the equipment to do the testing to understand, is this a small spastic bladder problem, or is this a really big overfull bladder problem? Because the treatments are opposite in most cases. So it is really important to get an accurate diagnosis in the type of urinary problem that's happening. So in terms of treatment, obviously remove any offending medications, right? We've talked about that for every symptom. And in particular, medications that are meant to make you pee, right? So diuretic medications. That's the first thing that I try to get rid of when I see them on someone's list. You want to treat constipation. So constipation by itself can cause people to have urinary symptoms, and it's primarily a mechanical problem. If the rectum is very full and it's very close to the bladder, your bladder is going to push up against something. It's not going to be able to fill as much, and you're going to have frequency. The other problem that can happen is it can cut off the flow from the bladder to the urethra, and then you're having trouble emptying your bladder. So constipation, it is very important to pay attention to constipation in people who are having urinary, if you're having urinary symptoms. Then we have non-medical interventions. So reducing things that would make you pee more, right? So reducing caffeine. Caffeine is probably the number one bladder irritant and diuretic and non-medical diuretic that I ask people to remove. Increasing your water intake. So in addition to increasing water, I want to make it clear, but we're talking about water and not just liquid, because a lot of non-water liquids contain either chemicals or colorings or additives that are bladder irritants. So for people who have a bladder that's already super active or spastic, adding a little bit of irritant in there is going to make things a lot worse. Just having very concentrated urine because you're not drinking enough water, that in itself is a bladder irritant and irritates the bladder and makes things worse with the spasticity of the bladder. So drinking more water is very beneficial. And then of course, pelvic floor therapy again, because they can address behavioral things, they can address positioning problems, they can address weakness problems or dyssynergia, and coordination of emptying the bladder. So I highly recommend pelvic floor therapy for people who are having urinary symptoms or constipation. And then medication. Excuse me. So there are anticholinergic medications, and these are effective, and they're used in a lot of people who have these symptoms outside of neurodegenerative diseases. The major issue, of course, is that these medications can worsen constipation. They can cause confusion. So they have negative side effects that are particularly onerous in LBD. So I typically try to stay away from them. Mirabegron, which is also called Myrbetriq, if you've heard of that one, tends to be better tolerated. That is one that has been tested in Parkinson's disease and seems to be beneficial. So if we are going to try to use a medication, I usually prefer that one. Again, this is all based on diagnosing the problem first, because these medications help you if you have the small spastic bladder that is going too much, but they hurt you if you've got the other problem where you're not emptying the bladder properly. So proper diagnosis is crucial, very, very important. Okay, I'm going to talk a little bit about excessive sweating for a couple minutes. So excessive sweating is what it sounds like. Sometimes it's only at night, sometimes it's during the day, sometimes it's both. I do always want to understand what the severity is. Are you completely drenching the bed? Are you having to change the sheets in the middle of the night? Are you having to change clothes during the day? Are you embarrassed to go out because of this problem? Are you having trouble sleeping because of this problem? The diagnosis is clinical. I do not typically use additional tests to try to understand what's happening because I personally don't find them to be particularly helpful. But one test that is there are sweat tests that can be done, and they can be helpful if we're not really understanding what's going on. They can also be used to sort of follow progression of the symptoms over time. So there are tests available. I don't typically use them. The treatments. So unfortunately, there are not many medications that we use, and none that have been tested specifically for this problem. The recommendations for LBD, for treatment of excessive sweating, is really doing things like wearing more loose-fitting clothes, especially if it's a problem during the day, using cotton bedding as opposed to non-cotton or non-organic fabrics, and then keeping the home cooler, especially at night. There's also some people notice that there are triggers for their sweating. So a very common trigger is very spicy food. So avoiding triggers can also be beneficial. Alcohol can also be a trigger for some people. And there are some people will experience sweating as a side effect of carbidopa-levodopa. Carbidopa-levodopa, also known as Sinemet, which is the medication we use to treat movement symptoms, um, especially in people who have dyskinesias, which is the extra movements. Those movements oftentimes can make people sweat more. So if we see that the sweating seems to be timed with the medication dosing, that might be a clue that lowering the medication can be helpful for the sweating. And then I will briefly touch on sexual symptoms. So, the symptoms, as I mentioned before, in men can range from loss of interest and anorgasmia, and to erectile dysfunction. In women, we see vaginal dryness, we see anorgasmia. We can also see loss of arousal or difficulty becoming aroused. As you can imagine, there's a lot of contributing factors. So, for diagnosis, the first thing that has to happen is that it's not going to get diagnosed if it doesn't get brought up in your doctor's appointment. And oftentimes it doesn't get brought up for various reasons. On the doctor's side, it might be that we're trying to concentrate on other things. We feel like we have other questions to ask, other fish to fry. And for the patient, it can be embarrassing, right? It's not something we enjoy talking about with anyone, really. But especially if it's something that's impacting your life and your relationship, which often it does, I would highly recommend bringing it up with your doctor, at least having a discussion and pointing you in the right direction of what can be done. Now, to diagnose, because there are so many contributing factors that can cause sexual dysfunction in LBD, we do have to be more careful about how we're looking for the contributing factors, right? What's going on. There can be psychiatric or psychological factors. Depression, anxiety can make you lose interest in sex. Marital problems or relationship problems can also contribute to that. May not be autonomic at all or physical at all. And then there's motor problems, right? Sometimes just the mobility problem can be enough that people lose interest or lose arousal, really, because it takes too long, for example. So that is something that we can address as well, not addressing autonomic symptoms, but addressing mobility symptoms. And then, there are, of course, apathy, so loss of interest in things that you used to find interesting or other people find interesting. Also goes back to psychological factors that can affect sexual function. And then autonomic, right? So the autonomic nervous system is what provides blood flow to the genital areas, helps with erections and arousal and vaginal lubrication, all those things and so we need to know if that's the primary problem. So in terms of treatment, of course, the treatment will depend on what the problem is. But if we're just talking about autonomics, first, I try to remove medications that might be worsening the problem or causing the problem. There are some antidepressant medications that particularly have these types of side effects. And if possible, I try to switch people to something else that may not have the same side effect profile, or remove the medication if it's not needed anymore. And then, as I mentioned before, just treating motor symptoms can also improve sexual function. So as a movement disorders specialist, of course, I'm also asking about the mobility aspect of sexual function and sexual activity. And then treating the psychological factors. So again, trying to understand where the problem is and not treating them in isolation, right? These are probably all contributing to difficulty with sexual function. There are things like sex therapy and sex therapists that can be very helpful. I, in all honesty, have not met anyone that has a specific interest in my patient population, but I know I have patients who have seen sex therapists in the area. So a lot of that ends up being homework for you, looking on Google and trying to find the right fit, but that is also something that's available. I wanted everyone to be aware of. And then I usually do refer people to urology. to see, one is to understand where the problem is because they have the diagnostic tools. And also there are medications and interventions that can be done that really can be very helpful. For urology can do this for both men and women, but I do find that women oftentimes prefer to see a gynecologist who can also address some of these problems for women. So, I think both are beneficial. I do want to warn that some of the medications that are used for erectile dysfunction can lower blood pressure substantially. So if you are someone who has low blood pressure or has orthostatic hypotension and you are taking some of these medications to help with getting an erection, sexual activity should be done in a horizontal position to avoid not feeling well or passing out. Okay, good. That leaves a few minutes for questions. Sorry, I talk a lot. So I'm happy to take questions. Let me stop sharing my screen.
You covered so much in that little bit of time. That was great. So
Sorry,
we do have some,
too. Yeah.
You did good. We have some questions, and I think the predominant one is about runny noses.
Oh, interesting.
Yeah, so talk to us a little bit about very runny noses, if you will.
Runny noses oftentimes can go along with the excess saliva, and we do find a strong association between excessive runny noses and trouble swallowing. When someone tells me about runny nose, one of the first things I do is check swallowing and send them to speech therapy because that's my biggest concern medically. In terms of treatment, things that we use for everybody else, like antihistamines and decongestants, we can use those things. They can be beneficial. I personally, just worry about side effects of medications as always. So we try things. Sometimes, we'll use things like those, like a scopolamine patch, things that are, you just have to be careful with those because they are anticholinergic and they can cause confusion, they can cause constipation, but they do tend to be a little bit better tolerated than some of the oral pill forms of those medications. Okay. Honestly, I've only had maybe 1 or 2 cases where I've actually had to treat someone for that. So yeah, unfortunately, it's one of those symptoms that's very annoying and is tricky to treat just because the medications that would be the most helpful are often the ones that we can't use because they could worsen other symptoms.
Mm-hmm. I'm sure you run into that with most of these things.
Yes.
Yeah.
Yes. Competing interests. Yeah.
Yes, definitely. You encouraged us to drink water, just water, real water. Yes. But there was a question about fizzy water or seltzer. Does that count as real water?
So my pelvic therapist, who I work with very closely, does not like fizzy water or seltzer water. She thinks it does also irritate the bladder. I'm not exactly sure how, because I don't see how that could get into your bladder. I think it's because there's additives that are, like quinidine and things like that. So it's not the fizz itself; it's just the additives that they put into the drinks that eventually can irritate the bladder. It depends, so I always tell people we go by what we have seen in other people and what we see in research. And unfortunately, there's just not a lot of research for these things in LBD. So we try things. I know for a fact that orange juice and, very acidic things and soda, caffeine, those are definite no-nos, but we can try with the, seltzer water and see if because I do know there are a lot of people who can't drink water. They hate water. So I always recommend, I'd rather have you drink water than and drink seltzer than not drink water. So if that's the only way to get it in you, yes, please try it. Please do it.
And so that sort of takes us to constipation and urinary sort of topics from there. What about somebody that, has at least moderate dementia? They've been taking a lot of medications for constipation. It's very difficult to get water or liquid in them at all. Do you have any other suggestions for that person that sort of feels like they've tried everything?
So pelvic therapy, I cannot say that enough either. So pelvic therapy, they do teach other things. So there are things like colon massage, for example. The water that's tough. The water is so important because a lot of these medications that I'm talking about, the Cilium, the Miralax, they require you to have a certain amount of water in your body because they are actually pulling water from your body into the colon so that there's enough lubrication to get things moving so you're not just having rocks in there. For people who are really not able to drink water, are constantly backed up. I mean, I do send them to GI, but what I see is they'll often do very aggressive colon cleansing things, like as if you're going to go through a colonoscopy. They'll do like that drink. They'll do something that's very aggressive, get everything moving, suppositories, and just clean you out and sort of reset. But the idea is to find a way to get that liquid in. I have one time had a case where we really couldn't get someone to drink enough water, and that was the reason that we ended up getting a feeding tube placed, because we just couldn't. It was only one time that was the only reason that happened. But that is something that I talk to my patients in this scenario about. That is oftentimes a time when it may come to a decision of, okay, we may just need it just for hydration purposes.
Sure. I know Heather shared on the chat, and we will share on the conference page some foods that are higher in water content and those kinds of things to help someone that's maybe not as severe as what we were talking about, but ways to get some more liquids into people if they won't drink. Dr. Sklerov, thank you so much for this. This was just an amazing amount of information. I know even in our office, we were all commenting on things that we picked up and little tips and things that you shared today. So we have all learned a lot, and we really appreciate your time and your focus on these very specific issues that are really challenging for our folks living with dementia.
Yeah. Thank you so much for having me. This is always fun for me to share these tidbits. So.
Well, we will definitely have you back to share again.
Sure. All right.
Thank you.